Okay, so we are continuing with our series of conversations, outlining clinical tools that will help us in our clinical life. And very frequently in the outpatient department, and this is Triage for students and interns who are listening, very frequently this particular patient profile or symptom profile comes to us in the outpatient department. You will see this on an ambulatory setting, meaning usually patients are subacute to chronic or subacute or chronically ill patients who present with this symptom complex. And we have to know a certain set of differential diagnoses to deal appropriately with this particular symptom profile. Nowadays, depending on the symptom complex, a lot of us are relying on extensive random testing that makes absolutely no sense. And this is not a derogatory comment on a certain clinical condition or a group of people, but it is a comment on applying one's mind to dissecting a patient's symptom. So the clinical case today that I am referring to or talking about is the following symptoms. Symptom 1, persistent cough, purulent sputum or mucopurulent sputum, which is increasing quantity and may or may not be accompanied by frank blood or streaking. So this is a very specific symptom complex, and clearly we are talking about the respiratory system. Bear in mind, there was a CT scan of the chest at the start of the video which kind of gave away the topic that we are talking about, but be that as it may, when we are referring to persistent cough, purulent sputum or mucopurulent sputum without streaking, we are talking about the respiratory system. You may think that this fellow who is talking about all these things is a little off. Is not a little bit, because he's talking about persistent cough and respiratory symptom as if he's giving preordained valuable knowledge or something like that, when the fact is self-evident. However, that is not the case. The reason I am trying to make a point of this being part of the respiratory system is because in your future careers or in your future clinical life, whenever you experience a patient who talks about cough, by default you should filter out the cardiovascular system out of the equation, and 9 times out of 10 you will be well rewarded to focus on the pulmonary or the respiratory system, because cough, and this may sound very silly to you at this time, but when somebody is talking about cough, the symptom by default originates in the respiratory system and not in the cardiac system. There are only a handful of conditions where you will have cough associated with cardiac conditions. Usual symptom that is associated with cardiac conditions is shortness of breath. And now you will say that there is shortness of breath associated with pulmonary system or respiratory system also, but the fact of the matter is that when you are dissecting the symptoms, that's the reason you are using your tool number 1, which is your history. Therefore, when on history, you have to listen very carefully to what the patient is saying. If his main focus is shortness of breath and then exertional cough or otherwise, it may be that he is talking about the cardiovascular system, whereas if his main complaint is cough with or without shortness of breath, he is talking about the pulmonary or the respiratory system. That's number 1. Number 2, the shortness of breath that comes with the respiratory system tends to come and go, meaning it is sporadic, transient. Now it can be persistent also, but here again we are talking about symptom complexes, wherein you are collecting your history with reference to all the symptoms that are relevant to a given problem or to a given system. Cardiac shortness of breath or shortness of breath related to cardiovascular symptoms or system usually is not episodic, it doesn't come and go. Of course there are always exceptions to the rule, but these are just two rules of the thumb which you can use in your clinical life to help you address the patient's primary complaint. Therefore, when you are taking history, do pay attention to what the patient is talking. I'm not saying that people don't do that, but sometimes if you're not interested in the patient, then the patient is not interested in you, and if your mind starts to wander, then he or she starts to wander. I mean, he doesn't come back, he or she doesn't come back to you. But anyway, so we are talking about a very specific symptom complex here. We are talking about persistent cough and purulent or mucopurulent sputum with or without streaking. By streaking, I mean not a patient who is taking off his clothes and running around naked, but we are talking about blood mixed with sputum. That is specific complaint of hemoptysis. Now, hemoptysis is not specific to the respiratory system. It can be related to cardiovascular system also, but there again, if you have cough and hemoptysis, you are well advised to think about the respiratory system rather than the cardiovascular system. The trouble with our differential diagnosis generation is that we are taught to remember 20 causes of a given symptom complex, when actually in real life all you would need or all you would have time for is 3 or 4, depending on the amount of time that you have. When you are sitting in the OPD, let's assume you are sitting in the KM hospital, you don't have time to think of 20 differential diagnoses for somebody who comes and presents with these complaints. And to go back to the complaints, they are persistent cough, mucopurulent sputum with or without streaking. And you are not going to think of esoteric causes or rare causes that are listed in the books, or that are listed in your handbook, or that are listed in your standard text that you may read. However, what you are interested in knowing is what actually happens in real life, or what actually happens in society, or what actually happens in the social situation wherein the patient presents with these complaints. And there may be many nuances to those complaints that he or she presents with. Now, you may say, cough with mucopurulent sputum, persistent cough, streaking, hemoptysis present, so he has alpha-1 antitrypsin deficiency, or he has cystic fibrosis, or he has Carter-Henner syndrome or Carter-Jenner syndrome, or he has immotile serious. I mean, all that is fine. That is all written in the textbook, but you have to keep your social circumstance or situation in mind. Therefore, I'll make another little clinical caveat there. While dealing with any given symptom complex, please pay attention to your social circumstances. And whether we like it or not, medicine is a social phenomenon. Medicine is a social business. So if you know the social background, your differential diagnosis is a little bit better than if you don't know the social background at all, and the only thing you know is textual material. That's not the best way to guide our clinical lives. So I would really advise you, exhort you, beseech you, plead with you to focus on what is the social background that is being presented to you. And for that it takes a little practice, it takes a little work, it takes a little effort, it takes a little talking to the patient, it takes a little more social experience, and so on and so forth. It all depends on your age and stage in life, but that's something that's going to be useful to think about and improve upon. And that applies to everybody. It includes people who have been around for some time and people who have not been around that long. So, but this is a useful tool to use in your clinical tool set. So coming back to the symptom and going back to the CT scan, I'll start with the CT scan, which is actually you have taken your history, and I will leave the history taking to you to some extent because there is no case or real patient here. So the history you have taken, and we will go reverse, or jump around a little bit, because after you have taken your history, the next tool that you have is investigation. And after the investigations, you have generated a differential diagnosis, and then after the differential diagnosis has been proven, or rather after you have taken your history and examination, the next tool is investigation, and after the history and examination you have generated a differential diagnosis which is proven or disproven by your testing. And the test has been shown first here, that is the CAT scan, which shows certain elements. And what the CAT scan is showing, I'll just summarize here, is showing certain cystic foci in the lung fields. Now these cystic foci are dilated air spaces, and those are black. as you know, on a high resolution CAT scan, air spaces appear as black and vascular structures appear as white. So the black air spaces which are distended are ectatic air spaces, or what we would call bronchiectasis. By bronchiectasis, it means bronchi which have become ectatic, okay, meaning they have become ecstatic and they have expanded, not ecstatic, ectatic. So they have become ectatic and expanded. So when you are looking at the CAT scan, this is a crude cross section, and it shows these bulbous, or excuse me, not bulbous but black cystic structures. These are the ectatic bronchi. Now, how do you know that these are ectatic bronchi? The way to tell is you compare this with your pulmonary artery or vein, the vascular structure, and the pulmonary artery or vein always accompanies the bronchus on the CAT scan, or even the respiratory bronchus. It goes all the way into the pulmonary sac, in fact, to form the pulmonary lobule, and that's where the air exchange takes place. But coming back to the CAT scan, we can't see at the level of the pulmonary lobule on general CAT scan, but if you do a high resolution CAT scan, you can see the pulmonary lobule and find which is the artery, which is the vein, and which is the respiratory bronchiole. But coming back, how do you know that these are ectatic bronchi? Well, when you compare those with your pulmonary artery or vein, you will find that these are much larger than the pulmonary artery or vein, because the pulmonary artery will be here, the pulmonary vein will be accompanying. So the pulmonary artery, if it is normal, is 0.6 to 1 times is the ratio between the pulmonary artery branch and the bronchiole or the respiratory bronchiole, okay? Whereas when the ratio increases, which means that the bronchiole becomes distended, ectatic, then the ratio will go on increasing. That means this will be 3 times the size of the pulmonary artery, and that tells you that there is ectasia of the bronchi, and therefore there is bronchiectasis. Therefore the CAT scan is showing bronchiectasis. Okay, so that's the clinical tool you can use for this particular conversation. Alright, coming back to the symptom complex. Like I said, the symptom complex is very specific. We are talking about persistent cough. Persistent cough meaning cough that has not been there for 3 or 4 days, but which has been there by definition for 2 to 3 months. And that's what means persistent. Okay, so for anything to be persistent in clinical life, it has to be 2 to 3 months. So, you know, if you are to be deemed persistent with reference to whatever it is that you are doing, you should do it for more than 2 to 3 months. So that's as far as the cough goes. And the second symptom was mucopurulent or purulent sputum, and that is accompanying the cough. So usually this is not a dry cough. So the differentiation between cough of these two types is dry cough and wet cough. If you have dry cough, usually your differential changes a little bit, and that too would be persistent. But dry persistent cough, your differential will change. But here we are talking about wet persistent cough, and it's purulent sputum with streaking, with or without streaking. But if there is streaking, then the differential is fairly straightforward. And the most important differential that comes for this symptom complex is bronchiectasis. Bronchiectasis by itself is a pathologic diagnosis or a radiologic diagnosis. There is a long list of conditions that would cause the bronchi to become ectatic. Now, pathophysiology wise, it could be that the surrounding tissue has gotten destroyed by inflammation, and inflammation can be immune or infectious. So if it was infectious, you would think about tuberculous, non-tuberculous, acute pneumonic causes, and non-infectious or autoimmune reasons would be rheumatoid arthritis, which are destroying the surrounding supportive tissue by inflammatory or autoimmune mechanisms, which is why the bronchi become stretched out, and once they stretch out, they become ectatic, and you have a bronchiectatic focus. Other mechanisms could be that you have a foreign body that obstructed one of the segmental bronchi, and once the segmental bronchi got occluded, it was easy to form stasis and recurrent infection in that area, and then the bronchi expanded again or became ectatic again because of fibrosis. So there are various mechanisms for bronchiectasis. I just described 3 or 4, and every time the bronchi get ectatic like this. The mucus production increases every time there is inflammation, because now the airway is not normal, the drainage is not normal. It's easy to form an infectious focus or a stasis focus which gets infected, and therefore the mucus production increases. So therefore that's the pathophysiology of the persistent cough and the increasing quantity of the sputum. So the quantity of the sputum is important. Alright, so now we need to generate a differential for this, and we said that the first diagnosis was bronchiectasis. Bronchiectasis and associated common conditions would be ABPA or allergic bronchopulmonary aspergillosis. It's not as common as we think it to be, but it can be seen. And non-common conditions would be cystic fibrosis and alpha-1 antitrypsin. So the common diagnoses that present with this particular picture, it's an important clinical picture which we frequently encounter in our clinical life, are infectious bronchiectasis, and that is usually TB and non-TB. The next one usually that presents with this particular symptom complex is COPD, and by COPD it is chronic bronchitis. People with the emphysema part of the COPD, they usually don't have as much sputum. The reason they don't have as much sputum is because their airways are so destroyed, or to the extent that they are destroyed is that they do not have enough airway to produce the inflammatory reaction from the mucus glands within the bronchi. So it is the chronic bronchitis part where the mucus glands are chronically inflamed by smoking. I mean, that's the most common reason to have COPD. That produces the inflammatory reaction and the mucopurulent sputum with or without streaking. There is streaking when there is inflammation, or there is streaking when there is breakdown of a blood vessel within the airway. So, and persistent cough is part of the smoking complex again, and it is part of COPD also, as well as emphysema also. For the purpose of this talk, we are talking about chronic bronchitis. So, infectious bronchiectasis, COPD would present with this symptom complex, and it's the most common differential that you will have to keep in mind. Now, that does not mean that everybody with this symptom complex has bronchiectasis, because bronchiectasis by definition is a pathologic finding and it's a radiologic finding. You can see it on an X-ray chest, and you can see it on a CAT scan. You can see it easier on a CT scan. You can see it on an X-ray also, X-ray of the chest. It's just that the bronchiectasis has to be slightly more profound. And to some extent, the textbooks describe all the structural kinds of bronchiectasis, like cystic bronchiectasis, saccular bronchiectasis, cylindrical bronchiectasis, and all that. And you can look that the types up, and there's a pathologic and X-ray diagnosis. So those are the common conditions, and the infectious bronchiectasis is likely most common in our situation. The tuberculous cause is again the most significant reason to develop this kind of a situation, and everybody who has TBA which has been treated and now comes with more and more sputum does not mean that he has resurgence or reactivation, but you have to think of certain structural changes that might have happened to the lungs itself that are causing the symptom to come about. The uncommon causes would be immotile cilia syndrome, and there's a whole symptom complex there, which includes Carter-Gainer syndrome and 2 or 3 other symptoms which I don't remember, like yellow nail syndrome and things like that, which I've never seen in my clinical life, and I don't think I'll ever see in my clinical life also. If you do see in your clinical life, congratulations, it means that you are very lucky, because you have happened to be in the pediatric wards or in the pediatric field, wherein you get to see rare things, which is fine. Alpha-1 antitrypsin is another one that gets documented, but again, it's not that common among our population. Not that it doesn't happen, but it's uncommon. So coming to the other investigations that we have to focus on with our list of differentials, you have to do simple things first. Simple things being the simplest is to take history and do an examination. With certain things, you're only going to go so far with your examination. I mean, even if you use your stethoscope and heard bubbling sounds or euphoric breathing or whatever other kind of breathing you're supposed to hear with bronchiectasis. But you probably should do some testing to prove your case or to list your differential in a satisfactory way or in a better way. So the simplest test would be X-ray chest, and you would look for these things on the chest X-ray. You might look for sequelae of TB, you look for sequelae of non-TB, you can look for segmental bronchiectasis if it was related to foreign body, or bronchial narrowing due to strictures, stenosis, post-inflammatory, or due to frequent mucus plugging. So that would be on an X-ray chest. Same would apply to a CAT scan of the chest, and you could do it as a contrast enhanced scan to see infectious issues, or you could do a non-contrast high resolution scan to see the relationship between the bronchi and the pulmonary artery and the pulmonary vein and the segments and the pulmonary lobule. You have to do a sputum. Nowadays sputum is shortchanged a little bit at undergraduate and even at graduate level. But sputum is important because we are dealing with all these infectious issues, and unless you have a sputum, there is no way you can tell that just by looking at the patient that you have non-tuberculous infectious bronchiectasis or just chronic bronchitis related to cigarette or BD smoking. But therefore sputum is a very important component of your basic testing. So what they teach us in microbiology does have relevance, and I would advise you to keep brushing up on those techniques for assessing sputum. You have to do sputum culture, and that would be for non-tuberculous and tuberculous bacteria. And if somebody had the condition for too long a period of time and notes that he is having some respiratory function reserve decrease, that is, he has some shortness of breath or exertion dyspnea, you would need a PFT. So sputum, X-ray chest, CT, sputum, PFT, useful. Okay. For the non-common problems like ABPA or alpha-1 antitrypsin or cystic fibrosis, that's another one that is not very common for our business. You might have to do a sweat chloride for cystic fibrosis. For ABPA, you have to do serology. That is your IgA and IgG titers. And once you have zoned in from the social and pathophysiologic origins of your symptom complex of persistent cough, chronic mucopurulent sputum, got a handle of what the X-ray and the CAT scan looks like, then you can form a treatment plan. Right? Thanks very much for listening.